All right, everybody. So this is going to be thriving in the endoscopy lab. Okay. You will most likely be giving quite a bit of anesthesia in endo. So I want to just talk about some of the different procedures that you're going to see in there. I'm going to give you kind of like my little cocktail recipes for colonoscopies and EGDs. And then we will talk about some worst case scenario stuff. So you guys will be ready to go. Right. So endo, you can also call it the butt hut. If you guys have any other fun names, let me know. But let's talk about inpatient versus outpatient endo because they are very, very different. Okay. So inpatient colonoscopies and EGDs. A lot of times you'll do these outpatient as well. Like you'll do them in the hospital. If I say inpatient, I'm talking like in the hospital. You still might do outpatient procedures on patients that are going to go home the same day, but either for insurance issues or whatever, they might still be done in the hospital or they don't meet criteria to be done outpatient due to BMI and other reasons like that. But inpatient, you'll be doing colonoscopies, EGDs. You will be doing these on patients, obviously, who've been admitted to the hospital for anemia or various things. EUSs, endoscopic ultrasounds, there's some more interventional stuff as well. ERCPs, you'll be doing those. And also in the endo lab, we're not going to talk about that today, but bronchs and EBUSs, endobronchial ultrasounds and bronchs. That's a whole other type of anesthesia. And if you're interested, I can do a video on that later because those anesthesia is very interesting. But a lot of times those are also done in endo lab at hospitals. Food boluses and managing GI bleeds and stuff like that. Hospital endo, the patients are usually extremely sick, especially if they're coming in from the ER and bleeding, or they're like sometimes the ICU patients you'll get. I mean, they are usually like ASA 3 and 4s. They have a lot of stuff going on. They could potentially be unstable. Yeah, it can be interesting in endo lab. So it's not just in the hospital, just easy peasy, straightforward all the time. Just FYI. Okay. And then outpatient, the places I go, I do a lot of 1099. There's a lot of really good gigs out there. Outpatient, colonoscopies, EGDs, and then flex sigmoidoscopies. You can do flex sigs also in the inpatient realm as well. Some people don't even use anesthesia for flex sigs, but essentially they're just going to go into the sigmoid and out. So it's usually pretty darn quick of a procedure. And we'll go through the anatomy and kind of how I dose things in a second. So just to kind of talk about a few things is for the most part, these procedures are essentially done MAC or monitored anesthesia care or essentially sedation by an anesthesia provider. ERCPs I've seen them done both MAC and I've seen them done both GETA, general endotracheal tube anesthesia, so completely out with like a tube. A lot of times it depends on the patient, it depends on the culture of the facility, it depends on the surgeon, and it depends on the anesthesia provider. I have done these, like I said, both. I trained doing them MAC, but I will, put a tube in if I need to. Because the patients sometimes they're prone, but they're kind of like in this weird tilty position and they're, so yeah. So just pay attention to that. Food boluses. Another thing is, I've done them MAC, I have done them with tubes, and you will find, once again, anesthesia provider, the surgeon preference, the patient, there's a lot of different factors. Sometimes you can do those MAC and if the food is stuck, like pretty anterior, they can usually pop it right down into the stomach. But these patients sometimes have a lot of secretions. It's not always safe to do food boluses MAC. So a lot of it depends. I have done them both. But something to think about, you're never, ever going to regret securing an airway. Like you're never going to have a time in your career where you're like, oh, I wish I wouldn't have put that tube in. You know what I mean? So you want to put a tube in and secure that airway. That is your right. That is your job. Do that. Okay. And then patients that come in acutely in GI bleeding, especially if it's like varices or anything like that. I mean, those can be extremely messy. The patients can be very unstable. And I usually will tube them because they're bleeding. You can expect a pretty bloody, crazy airway. Those can definitely be emergencies. So just so you know, in the hospital, you will be stretched doing endo. It's not as easy peasy. And then outpatient, like I said, it's very much going to be just sedation, pretty healthy, generally healthy patients. Usually, you know, the docs I work with are pretty cool. It's a pretty nice day, very fast turnover usually, but usually a good day. All right. So before I give you guys my little cocktail and some recipes, you always, from an anesthesia standpoint, whenever you are doing anything, you always want to be thinking worst case scenario. What is the worst thing that can happen, right? So even if you're doing tons of MAC cases and you're just seeing a little propofol and everything's going great, right? You still want to have an LMA available. You want to have a tube available. You want to have suction available. Like, you know, airway stuff sucks at least in the Pyxis or somewhere, right? You still want to have all the things available because things can still go extremely wrong. Especially when you're in doing an EGD, you're essentially sharing the airway. And so the patients can laryngospasm, like that can absolutely happen. So being able to recognize that if they are not deep enough or a piece of spit gets down there, usually the endoscopists, the docs are really good about suctioning out, you know, the larynx and everything for you. But laryngospasm is something you need to watch for and look for. Patients going apneic. Now, we give a lot of propofol. Sometimes even you give them a big bolus, the patient goes a little bit apneic, they pop the scope in, they come back breathing. Usually it's not a big deal. But if you have a more frail patient or a larger patient or a patient with comorbidities, they're not going to handle the apnea. You have to kind of know when to have them pull that EGD scope out. And, you might have to mass BVM, like bag mass ventilate them, either with your anesthesia machine or have a bag, have a BVM bamboo bag and everything in the room. So things to think about. You're still going to be checking all these things when you are in the endo lab. And these can also happen with colonoscopies as well, right? I've had people coughing or have secretions with a colon and they can still spasm. They can still go apneic. You just have, you actually, a little bit more control of the airway on a colon than you do when you're sharing the, airway with an EGD. And I always still stand at the head of the bed. Like I'm at the head of the bed until that EGD is over. And then, either the procedure's over or maybe we'll do the colon next, but I'm always standing up there at the top. Always make sure you have suction available as well. And then of course, a can't intubate, can't ventilate scenario. I did have one time I was doing a patient for an ERCP, and patient had a gallbladder surgery recently, was super distended, had been NPO for like forever. And I went to tube them and literally just contents and aspirate came out everywhere. And it was scary because I had difficulty intubating or difficulty ventilating, really hard to see with intubation. It was scary. I ended up having to cancel the case, and it was like this whole big thing. So, same thing with these sick patients coming in, aspiration risk, depending on what's going on with their stomach, their GI tract, the gallbladder, all those things tie together, right? And then if you obviously, like we said before, bleeding, any really bad bleeding issues and stuff like that. I mean, I have tubes people drop central lines in the endo lab. I mean, sometimes things go crazy. Other big things that you worry about is a colon perforation during that. If this happens, sometimes you don't always notice it, especially if patients have like diverticulitis, reticulosis like that. But sometimes you don't always notice that during the case. But if a patient has really, really bad tenderness and pain afterwards, and they're kind of relieving that because they do fill the colon up with gas so that they can see, or like air, so that they can see, and then they have to pass that gas out at the end. But if they're doing that and they're in a lot of pain, you just want to be thinking about potentially, did you get a perf? Sometimes the docs will reach over and just make sure the belly is like soft if it's like a really twisty, hard colon or anything like that. But essentially patients could start breathing really quickly. They can get very tachycardic. They could, start getting like they're going to throw up. They could have problems breathing. It all just depends. Like it can be very mild and it can be very severe and intense. And they've got to like call the gen surgeons, like we're coming in. And so then it's your job just to kind of monitor that and like, okay, do we need to get that airway secured? What are our hemodynamics, stuff like that. But always just something, like I said, like that's the job, right? Of always thinking about what could go wrong and am I prepared if the worst case scenario happens, and knowing what you're looking for as well. Let's talk anatomy and drugs really quick. Once again, there are a million trillion ways to give an anesthetic. Okay. I think we all know that. I think you guys see that when you're in clinical and your preceptors and all that. So these are just some ideas of what I can do there, or what I do like to do. There's always, excuse me, situations where you have to, maybe add in a little Precedix or a little ketamine or whatever it may be. We have a lot of good stuff in our toolbox. And so, especially when you are not so much outpatient, but when you are inpatient and you are having these scenarios coming in, you're going to be thinking about, okay, how can I maximize the drugs that I have based on what's going on? And propofol is extremely vasodilating. So sometimes, yeah, a lot of times I just give straight propofol, right? For at least for colonoscopies, just straight prop, it'll get it done, no problem. However, sometimes you have a really sick patient and you give a little bit of everything versus one of one thing. It can be very helpful. So maybe I give 0.5 milligram of Versed or one of Versed or 25 or 50 mics of fentanyl, and then I don't have to give as much propofol, right? So you're always thinking of these things. Or maybe if it's like we're doing a top and a bottom, an EGD and a colonoscopy, maybe I give just like 10 of ketamine, like a little touch of it, and then a little prop, right? So you can give one of one thing, and you're going to get a lot of that side effect, adverse effect profile, potentially, or side effect profile. Or you can give a little bit of everything, and then you lessen that adverse effect profile. So just all the things to think about. There are 1,000,001 ways to do things. So for EGDs, essentially the most stimulating part is kind of getting past here. So you want them somewhat deep as the scope is being introduced down the pharynx, larynx, and then down into the esophagus. So what I tend to do for EGDs is a lot of people give glyco. You can also give Robenol, like 0.2 milligrams, to help dry up secretions, potentially, especially with, smokers tend to have a lot of secretions, because that'll help decrease your laryngospasm risk that we just talked about. So some people will give 0.2 milligrams of glycopyrrolate up front. I tend to give 25 to 50 mics of fentanyl, usually 50, right up front when they hit the room or when the doc walks in the room, because fentanyl is going to peak in about 2 to 3 minutes. And I want, as they're introducing the scope, I want that fentanyl to be peaking, because what that does is it helps blunt those airway reflexes as well. Like it really does help kind of smooth out the scope passing. So I will give 50 mics of fentanyl. I'll usually give anywhere from 30 to 50 milligrams or 100 milligrams of lidocaine as I'm giving the propofol to also help. And then it helps with the burn of the propofol as well. And then I tend to give like a decent kind of, once again, it depends on the age of the patient. Sometimes I might give 20 milligrams of propofol if it's a really sick patient, right? Especially if I've got that fentanyl that's going to start synergizing and working. Other times I've got a nice healthy person, I might give them 70 milligrams of propofol up front, 100. It all kind of depends, but nonetheless, I give them kind of a big slug. You might have to kind of jaw thrust a little bit to help them pass that scope. And then usually once they go down, you can, depending on how big of a kind of a bolus you gave, sometimes you can ride that out, depending on how many biopsies or whatever thing they need to do. Or sometimes I'll just give an extra kind of 2 to 3 cc's, 20 to 30 milligrams of prop, and usually that's enough. And then by the time they get the scope out, they're awake and, opening their eyes and kind of waking up and ready to go. Okay. So that's what I tend to do for EGDs. For colonoscopies, like I said, for the most part, I really just do straight propofol. You can usually get away with straight propofol. I usually do not give fentanyl for any type of colonoscopies. If I'm doing a double, an EGD and a colonoscopy, sometimes I will give one of Versed, 50 mics of fentanyl, and then that, just because it kind of helps really smooth them out. It's going to be a bit of a longer case. A lot of it depends on getting to know your docs, right? There are some docs that are quicker, some are medium, some are slower. It just kind of depends. You kind of have to know them as well. And the more that I work with some of the people I know with, the more I just know them. And then you can just get a really nice anesthetic because you just know how they're going to work and what's going to happen, et cetera. It takes time, right? Everything in life takes time. And you're always going to get humbled because it's anesthesia. So just when you think you got it, something will humble you. Don't worry. So anyways, this is essentially for the colonoscopy. They're going to go the rectum into the sigmoid, descending past the splenic flexure, which is kind of a sharp bend, transverse, hepatic flexure, ascending colon. They can also, sometimes they'll pop into the small intestine. There's like a little, like they can divot on into the small intestine. Then you have your appendix. Sometimes you will be able to check out where that is. And then the cecum. The cecum is like the holy grail. Like you've made it to the cecum, right? That is like the end of the colon. But essentially what I do for these, once again, give a nice big slug of propofol going in. Kind of the most stimulating part is kind of in the rectum. And then sometimes when you get to these flexures, they can be twisty turvy, winding, and sometimes, and I find too, kind of sometimes getting in the transverse and in here, it just tends to be kind of stimulating going around kind of like this top part of the colon. So a lot of times I'll give them a nice big slug. I'll give them a couple more like slugs of propofol, like as we're kind of getting in there. And usually when you get to the cecum, like there's coming out is really not that stimulating for the most part. Like the most part is getting in, kind of getting through this. And then once you get to the cecum, it's kind of like, oh, they kind of relax. So depending on if they're going to be doing a ton of biopsies on the way out, did they see a lot of polyps? Sometimes they're going to get a few polyps going in. Other ways, they're going to get all the way to the cecum. Then as they come out, they'll be grabbing some polyps. So it kind of depends on how busy like the colon is. But essentially, once you get to cecum, what I tend to do is, once again, I give them like another big old slug. And usually they can ride that out as they kind of journey back through the colon. When they get to sigmoid, I'm usually done giving anesthesia at that point. Because as soon as you hear like they're in sigmoid colon, and this is usually like when you have like your colonoscope, if I see that they're at about like 5 to 4, the number on their scope, I usually know that we're about done. So I'm always kind of paying attention to see where they're at. And if they're, 5, if the number is like 5 to 4, because it's going to go 3, 2, 1, then they're going to be out of the colon and be done. So a lot of times I'll peek over and just literally look at the number where they're at, because essentially they're getting really nice and light in here. And then when they come out of the rectum, I can usually have the patient nice and awake. By the time they're done, they're nice and awake in recovery, and then they can get them out and on to the next. So that's really why I just put up here about knowing your anatomy and where they are, because you can dose your propofol according. Now, to use a pump or not to use a pump. I kind of do both. Some places I go to, they have propofol pumps. If I have it, I'll usually give them a big, bump of propofol to get in, turn the, pump on 50 to 100 to 120 mics per kilo a minute, just depends. And then maybe turn the pump off kind of like as we're transverse and descending kind of around here, and then just have it if I need it. I just kind of always just hand pumped it. Like I trained like that. My first, like my job outpatient was hand. So, and plus, the people, the anatomy. I tend to just use my hand more than anything, which I know some people are probably like, oh my God, I need a pump, but I just kind of, hand it. And then, by the time they pull out of the rectum, I usually have the patients pretty awake, and they don't remember anything, but they're still like, ready to go. So to pump or not to pump, you're gonna have to put me a comment below on what you guys like to do. It, like, once again, this is just what I do, right? There's no right way. There's just the way that you make right, the way that you make work for the procedurist, the doctor, the patient, you know what I'm saying? Like there's just so many ways to do things. So I just wanted to give you guys a little peek into how I do things. So yeah, if you guys have any questions or anything, let me know. I usually, for the most part, enjoy endo. It's usually, I hope I didn't scare you with some of the things that can go wrong, but it's good. Anytime you're doing sedation or MAC anesthesia, it's a skill. It's a skill. And I just encourage you guys to keep building that. And I would love to hear your guys' recipes and what works for you below in the comments. Have a good one.